स्लाइड हो?
नहीं सर वैसे भी हो जाएगी, फर्स्ट टाइम ने कलेक्ट वैसे करना पड़ता है।
Okay. Okay, I'm Dr. Mohammed Jamil, and today we are going to discuss the pediatric orthopedics or disorders of the pediatric orthopedics. Okay, there are a lot of the topics that we have to discuss, but I have selected the common topics that are important. Okay, the common pediatric orthopedic problems are DMD, that is the Duchenne muscular dystrophy, clubfoot, DDH, developmental dysplasia of the hip, endoengate. Common hip condition in the pediatric and adolescent population are the transient synovitis, SUFI, that is slip capital femur epiphysis, leg tear, or disease. Okay, first we will discuss the Duchenne muscular dystrophy. This is caused by a defective gene located on the X chromosome responsible for the production of dystrophin. Dystrophin is the important muscle fiber membrane protein. Clinical onset of weakness usually occurs between 2 and 3 years of age, and most were present by the age of 6 years of age. There is a patient who present to us at around the 5 or 6 years of age. Okay, the affected children usually have varying degrees of the mild cognitive impairment. Okay. Muscle weakness affects the proximal before the distal lower limbs. There is the proximal muscles are affected. For example, the lower limb, the thighs muscle around the thighs and in the forearm, the arm muscles around the shoulder muscles, shoulder girdle muscles will affect. Okay. The features, associated features are the cardiomyopathy. It results in the cardiomyopathy and conduction abnormalities, bone fractures, scoliosis, pseudohypertrophy of the calf and quadriceps muscles, lumbar lordosis, widening gait, shortening of the Achilles tendon, hypo or areflexia. Okay, you can appreciate all the things in the picture. Okay, this is the shoulder muscles. You can see this is weak. All the muscle around the shoulder muscles are weak, and the shoulders and the arms are held backwardly when working. Okay, and the belly sticks out due to the weak belly muscle. The thigh. If we should look at the thigh and the muscles around the thigh and the glute region are also weak, and this is the hypertrophy of the calf muscles. Okay. Okay, DMD is the most common fatal disease affecting children in the United States. Patients with DMD are often confined to a wheelchair by the age 12 years and die in their late teens or 20s from respiratory insufficiency or cardiomyopathy. Elevated levels of the serum CK, creatinine kinase, and EKG abnormalities in the heart are common. Muscle biopsy confirms the diagnosis with genetic studies online. Okay, so what should be the treatment of the Duchenne muscle dystrophy? Treatment aims at preventing the complication. We can't reverse the problem because it's a genetic disease. Okay, so what we are going to do, we will prevent the complication. What are the complications? The respiratory complications. So volume, we will do the volume recruitment, deep lung inflation, manual and mechanically assisted cough techniques, nocturnal ventilation, daytime ventilation, vacuum. Orthopedic interventions to prevent the contractures, nutrition and weight monitoring, dietary calcium and vitamin D supplementation, exercise to prevent disuse of. For boys 5 years of age and older who are no longer gaining motor skills or whose motor skills are declining, glucocorticoids, cortisone, or eflazocar immediately. Okay. With left ventricular ejection fraction less than 55% or left ventricular dilations, beta blocker or angiotensin enzyme inhibitor are given. Okay. The next problem that is very common in the patient is the clubfoot. I think you will also saw the patient in the clinical setting. Okay. Introduction. What is the introduction? Well, the other name of the clubfoot is the congenital spondylitis. It's a complex deformity of the ankle and the foot, involving abnormalities of the bony architecture and soft tissues. A deformity in which the foot is twisted out of its normal shape. There is a normal shape of the foot is lost. Okay, and when you are going to autocorrect the position, it will not be corrected. Now there are certain terminologies you should know. What is the talibis? Talibis is the foot and ankle. When we say talibis, we are talking about the foot and ankle. Varus is the bending inward, and valgus is the bending outward of the foot. Equinus when the toes are lower than the heels, and calcaneus when the toes are higher than the heels. Talipes equinovarus. Okay, in the picture, look at the picture. The foot is in equinus. Okay, and this internal rotation of the foot. The Achilles tendon is contracted. Okay, when there is a plantar flexion, the foot is deviated medially and the foot is twisted inward. That is the varus. So it is one in 700 to 1,000 live births. Boys more common in the girls. Okay. What is the etiology? Everyone asks about the etiology, but what is the etiology of the clubfoot? It is arrested development during the 9 weeks of embryonic life, but the feet are formed. The talus is deformed, the Achilles tendon is shortened. There is also a certain amount of genetic predisposition. If monozygotic twins has clubfoot, the other twin, their chances increase to 32%. Cousin marriages 3% and second degree cousin marriage is 0.6%. What's the pathophysiology? Pathophysiology, the amnion forms, the constructive bends formed around the feet and the uterus. It's called amniotic bending. That results in the cutting of the circulation to the feet. So abnormal arrest development that result in the club. Arrested fetal development. Skeleton and soft tissue during the gestation weeks 9 and 10 when the foot development occurs. Abnormal neuromuscular dysfunction, muscle abnormalities. So defect the primary germ plasma. Ankle dysplasia. Okay, so what are the clinical features? You saw in the first picture that the foot is in adduction. So forefoot in adduction. There are 3 or 4 main deformities of the club foot. There is a forefoot in adduction, the hindfoot in cavus, the midfoot in cavus, the hindfoot in varus and equinus. Okay. Why? This is the contraction of the Achilles tendon leading the plantar flexion. The plantar flexion of the foot is okay. The foot is also inward to the lateral border instead of downwards. Thin and atrophy. The calf muscles are thin and atrophy, and the lower leg, the reflex tibia, is also short. The diagnosis is physical. X-ray, the physical examination, if you find all the factors, there is equinus, forefoot connection, and cavus, and varus. So it means it's a club foot. Sometimes we do the X-rays, but the diagnosis is based on the clinical examination. Sometimes the prenatal diagnosis can also be done by the ultrasound. Okay, the management of the core. Okay, for walking, we need a planless, planted weight, and steady foot. Stages of the treatment. First, we have to correct the foot. Then we maintain the correction until the normal balance is regained. Okay. You may also heard about the Dennis Brown splint. Dennis Brown splint is splint which begins about 2 to 3 years after the birth. It is made of 2-foot plates attached to a crossbar. The infant's feet may be attached to the splint with adhesive tape, 12 foot. I will show you a picture of this. Protect the feet from salt and check skin for redness in areas. This is the picture of the Dennis Brown shoes. Okay, this is the bar and these are the shoes. So this bar keep the foot in abduction. The foot abduction also maintain the rotation of the foot so that we maintain the corrected foot in normal position. Okay. Now the standard treatment of the club foot is the manipulation of the Ponsonby method. What is the Ponsonby method? The Ponsonby method is the casting. We do the manipulation, gentle manipulation of the foot every week. Every week we do the gentle manipulation of the foot. And after the manipulation, we apply above knee cast, complete cast. And the next week we remove the cast, and when we remove the cast, again we do the manipulation, there is further correction, and we apply another cast. So this process complete up to the 6 weeks. At the last cast, sometimes we do the tenotomy of the Achilles tendon, and then after tenotomy, the last cast may for 2 to 3 weeks. Okay. So when the last after date, when the foot is corrected, we apply the Dennis Brown shoes. Okay, this is the correction. This is the positive method. This is gentle correction. This is the first cast. Okay, this is the second cast. Usually after gentle manipulation, we do the abduction, further abduction, further abduction. When we go this abduction, 60 degrees, So this is the fifth cast. In the fifth cast, when we get the plant to grade put on 90 degree, then we do tenotomy at this stage and we get the normal put that's 30 degree of dorsiflexion of the foot. Okay, surgical management, tenotomy. Tenotomy is a part of the concept technique. But when we do the surgical techniques, the name is the posterior medial release. We do the posterior medial release. In this release, what we do the Achilles tendon release, and other structures that release are the tendon shoulder, the muscle crossing the subtalar joints, posterior ankle capsule, and the quad ligament, inferior tibiofibular ligament, fibulocalcaneal ligament, or capsules. That is the all the structures around the ankle and the talus. They are causing hand vessel that are tight. We release all the things, even the plantar fascias also. After the release, we do the cast again. The next topic that is very important is the congenital hip dysplasia or developmental dysplasia of the hip. It refers to a variety of the conditions in which the head of the femur and vestibular cavity are improperly aligned and the femur head lies outside the hip socket. Vestibular cavity. It could be unilateral or bilateral. Okay. What is in instances 1 in 1,000 live births in female patient is more common. Breech presentation in left side is common. Like 60% of the left side of the hip is common. 20% is bilateral and 20% both hips. Okay, 20% right side, 20% bilateral. So the most common on the left side. What are the risk factors? Are the genetic factors and the prenatal factors. The prenatal factors are the maternal hormone imbalances, intrauterine positioning, large baby, multiple fetuses, and oligohydramnios. There are two types of congenital hip dysplasia, typical and developmental. Typical in this the infant is neurologically intact, while the terminological congenital hip dysplasia, it involves neuromuscular defects like arthrogryposis and myelodysplasia. Arthrogryposis is a congenital joint fracture when two or more areas of the bone. Okay, now according to the disease, it is the how the deviate is. It is in the stage of pre-luxation. For example, there are chances to subluxate or dislocate. So, what is the pre-luxation degree or pre-luxation stage? It's mild form, very mild form is pre-luxation, or the acetabular is dysplastic. Dysplasia reflects delay in the acetabular development. Osseous hyperplasia of the acetabular roof, which is oblique and shallow. You can see the acetabular is, and this is oblique and shallow. This is the deep, the acetabular is deep, but it's oblique and shallow. The cartilaginous roof is comparatively intact. Femoral head remains in the acetabular. It means this problem is in the acetabulum. The acetabulum is not properly formed, so it is dysplastic. So if it is dysplastic, so the acetabulum will not deep and it will become shallow. So chances of the subluxation or dislocation is more. What is the subluxation? This is the large percentage of the CDH is subluxation. What is the subluxation? That is the incomplete dislocation, or you can dislocate the head by the examination, by the palmar and ordinalis. You can dislocate the head. You can examine intermediate stage in the progression from the dysplasia to complete dislocation. Femoral head. This femoral head is in contact with the acetabulum, but partially contact. The stretch capsule or ligament of the femur causes partial displacement of the femur head. Pressure on the cartilages inhibits ossification and the socket is flattened. Okay, this is the dislocation. Okay, this is the most severe form. The femur head loses contact with the acetabulum. You can appreciate this. This is the dislocation. This is the hip socket. Okay, this is the hip socket, and you can appreciate the head is here. And normally the head is present in the socket, so the head goes upward. It is displaced posteriorly and superiorly, and round. This is the round ligament of the femur. It is elongated. Okay. So the femoral head is not in contact with the socket. What is the pathophysiology of the developmental dysplasia of the head? And is all the structure of the hip joint is the acetabular femoral head and capsule or not properly developed? So the partial or complete dislocation of the femoral head from the shallow cerebral cavity. What is the clinical manifestation? It's important that how you will diagnose the patient. In infants, the legs will be short, the asymmetry of the legs, asymmetry of the gluteal folds. When your infant is prone position, you can appreciate that the gluteal folds are asymmetrical. The affected limb will be limited range of movement. When you abduct the hip, it will not be, there's a restricted abduction. Short femur on the affected side. After 3 months of age, the affected leg may turn outward and become shortened to the right. Okay, in older children with unequal legs of the land. So this is you will appreciate the in older children with gait abnormalities, who stop walking or limping. How you will diagnose the age? This is also if the patient come as an infant, you will examine. So examination is important. The clinical examination, you can say that it is lineage or not. Okay, or if you want to do some investigation, so before the 6 months you will do the ultrasound. And ultrasound is the diagnostic in 6 months. After 6 months, we do X-rays. Okay. In older children, we do the Galeazzi sign. What is the Galeazzi sign? We flex the hip up to 90 degrees and measure. When we flex, so there will be the discrepancy in the height of the femur. So we can appreciate here that this femur is down. So there is the dysplasia or here, if it's dislocated, and there is the Galeazzi sign is positive. Okay, there are periodically after 6 months of age, we do the X-rays, and there are certain important things. There's a line we draw from here, straight line. In the tricranial cartilage, other line we draw here to the outer margin of the acetabular. So this head should be here in the inner lower quadrant. So this is normal. But you can appreciate that the head is in the inner outer quadrant. So this is dislocated. You can appreciate in this X-ray that is the head is normal, the head is dislocated, and acetabular index is 45 degrees, which means that this acetabular is shaved. Okay, this is a line, one vertical line. This should be processed to the center of the acetabular like this. It is crossing in the upper border, so it means that it is dislocated. Okay, clinical signs. This is very important. Start with the boundary signs of autoimmune sign. What is a Barlow sign? A click is formed when the infant is placed supine in the abducted, which is flexed 90 degree, knees fully flexed, and the hip adducted to the midline. Okay, autoimmune is placed on his way with the hip flexed and an erection while the examined portion, the femur downward to dislocate the hip. A click check indicates subluxation and movement, subluxation in an older infant. Okay, this is the Barlow, this is the Barlow test. Okay, what he is doing, examiner adducts the hip while applying a posterior force. You can see the doctor or examiner holds the knee in a hand. Okay, and then what he is doing, he is applying a posterior force on the knee to promote the dislocation. Okay, adducting and posterior pressure. While what he is doing, abducting and anterior force, anterior pulling, abduction and anterior pulling. And with the finger, it pushes the trochanter to the hip, so it's relocate the femur. Trendelenburg test. When the child stands on the affected leg, the opposite pelvis dips to maintain the erect posture. Okay, management. Management below the 6 years of age, we apply the Pavlik harness. This is the Pavlik harness. It has anterior strips and posterior strips. The anterior strips to maintain the flexion, and while the posterior strips to maintain the abduction. For children 6 months to 2 years, when the children are more than 6 years of age, so what we do the close reduction under the general anesthesia, close reduction of the hip under the general anesthesia. Sometimes we do the adductor tenotomy also, and then we apply the hip spider cast for the 12 minutes. Abductional process for vestibular remodeling. Okay. When the children come after the 2 years of age or 2.5 years of age, we do the open reduction surgery. Open reduction, we do the hip joint is used for openly, and the femoral head is sometimes placed in the upper portion or more distance. So we do the femoral shortening. You can appreciate the femur. We cut the femur and remove some part of the bone and After age, we also do some rotation of the feet. Varus is called varus deviation osteotomy, and sometimes we also do the pelvic osteotomy to deepen the vestibular. After the relocation and all the things, we do the course of the spine. That is for two pelvis. This is the X-ray to the operative patient. This the hip is in dislocated position, okay, and vestibulum is shallow. So this is the osteotomy done for here, and the screws are applied for here, and then the femoral shortening done, and now the femoral head is in normal position. Okay. Other important topic is the in-toing. What is in-toing? Okay, most of the patient come in with the in-toing. Sometimes the patient come with or the parents don't bring the child, and so the child is walking with the toes in. Okay, this is when you ask the child to walk in a straight line, so always the toe goes inward in this direction, and outgoing that is the toes going outward. There are the three important causes of the in-toing gait: metatarsus erectus, internal tibial torsion, increased femoral anterior. These rotational variations are related to the intrauterine molding and resolve spontaneously in normal growth and development. So first we will discuss the metatarsus erectus. The metatarsus erectus are the knee rotations of the forefoot on the hind foot. Okay, this is the motivation, and the foot is in the form of C shape. You can see the sheet C shape, and this is common around the 1 year of age, or when the patient is younger than 1 year of age, it's common that, and the patient is C shape. It usually resolves by itself after 2 years of age. The next is the internal tibial torsion. The internal tibial torsion, it is a rotation of the tibia, or internal rotation of the tibia in relation to the transcondylar axis of the femur. It's the most common cause of in-toing in the children between 1 and 3 years of age. Okay, below 1 year of age, what is the cause was metatarsus erectus. After they come to 3 or 4 years of age, the internal tibial torsion is the cause. It is characterized by foot that points inward when the patella faces forward. Patella will face forward, the foot will points inward. It means that the tibia is rotating. Neutral or internal thigh foot angle. Internal tibial torsion usually resolves spontaneously by 5 years of age. Okay, this is the thigh foot angle. We will draw a line, in straight line, longitudinal line in the thigh, straight line. When we draw the line in the plantar surface of the foot, that passes through the center of the heel and the second interdigital space. Okay, there's a second and third toe from here to here is a straight line, and we measure the angle. This is the external thigh foot angle, means this is external rotation of the foot, and this is the in-toing. In in-toing gait, this will be the negative foot angle. Okay, this is the negative. So increase femoral anterogram. Increase femoral anterogram is an increased angle of rotation of the femoral neck in relation to the transcondylar axis of the femur. And it is the most common cause of the in-toing gait in children older than 3 years of age. It is characterized by inward facing feet and patella during walking and standing, exhibited pattern during the run, symmetrical increased internal rotation and decreased external rotation of the hips. Okay. Preference for sitting in the W because the children will sit in the W position. It tends to improve spontaneously by 11 years of age. Okay, this is the patient. This is the kids. The kids will sit in the W position. This is the external rotation of the hip. So it means the external rotation is more. Most children with the rotational variation of the lower extremity can be followed in the primary care office. Means we do the observation for these children. Pathological conditions that must be considered. For example, if as I told already, the metatarsus erectus, it will resolve around the 2 years of age. The internal tibial torsion will resolve around the 5 years of age, and the femoral anteversion It will resolve around the 11 years of age. But if these things remain persistent beyond their correction age, so it means there should be certain other problems. So we have to exclude these problems. Then we have to observe the patient up to the particular age, and side by side we will we will also search for the other problems. What is for example, what are the other problems? Is that these are the neuromuscular diseases, for example, the cerebral palsy, disorders of the hip, for example, the PDH, lower leg deformities, for example, the skill foot or cleft foot. Okay. The most important aspect of management of the patient loss in chronic is parental reassurance. With most deformities correct spontaneously, and even in the persistent cases, adverse long-term sequelae are rare. Non-operative intervention, for example. Okay, sometimes in non-operative intervention, we give the shoe inserts, braces, twisted gavels. Casting are ineffective in the treatment of internal tibial tendon but increase femoral activity. Indications for referral include referral means when we do the surgeries for this, there is a rigid metatarsus. Rigid, okay, the metatarsus will not be formed by the 2 years and still there are in. Or when there is a unilateral asymmetrical implying with findings suggestive of a cerebral palsy developmental hip dysplasia, dislocation of the hip, cosmetically or functionally unacceptable, implying due to the internal tibial tendon in a child older than 8 years of age. These are all the deferred. Okay? Cosmetically or functionally unacceptable, implying due to the femoral activity in a child older than 11 years of age, implying that does not follow the expected clinical course. Okay, now the other important topics are there's another one. There is a slip capital called upper femoral epiphysis. What is this? This is the displacement of the proximal femoral epiphysis. It is most common cause of the hip pain in adolescents. In males greater than females, 3:2 ratio. It affects the males in 12 to 16 years of age, while it affects females in 10 to 15 years of age. It's bilateral and central to 50% of cases. What are the risk factors? The risk factors are obesity, history of radiation therapy to female head, endocrine disorders, for example, hypothyroidism, and osteodystrophy of the chronic pain, past family history of the Sufi. For example, when it is autosomal dominant, so if in the family any other kid has Sufi, so there are chances of the another kid or a kid can got or they can get Sufi or Africa. Clinical presentation. Pain. The important thing is pain, hip or groin pain. Or a peripheral pain, the patient may also complain the pain in the anterior part of the thigh or knee. On physical exam, or the patient can get the pain and the limping gait. The limp will be due to the pain. In the physical examination, the Trendelenburg gait. Okay. The legs is externally rotated and it will be short. And it is moved to short, the limping, while the patient can get the pain or when it is due to short limping. Limitation of the abduction and connotation. It means the range of the movement are limited or decreased, especially the abduction and connotation. Okay, this is the normal X-ray, and this is the head of the tumor, and this is the neck. So we draw a line in the upper part of the neck. This is the bottom of the neck, and this is the lower part of the upper bottom of the draw a straight line. So it should cross through the epiphysis. But in slip femoral epiphysis, there is very slip over here. So this line will pass above it or to its upper border. So it is called Klein's line. Okay, this is another line which is drawn. Okay, you can appreciate epiphysis over here, but there is no epiphysis. Epiphysis is slip right. Okay. So if grading, it's mild, moderate, or severe. When the epiphyseal displacement is less than one third of the femoral neck, or angular slip is less than 30 degrees. There is a slip is less than 30 degrees. When the displacement is one third to half of the femoral neck, that is the displacement is 30 to 60 degrees. That is the moderate. Severe is when the displacement is greater than 60 degrees. Treatment management, non-weight bearing and rest. The management depends upon the degree of the slip. In the type 1 or mild cases, we just allow non-weight bearing and rest. The surgical procedure we do in the type 2 and type 3 cases in the moderate and severe form. In the moderate and severe in both, we do the percutaneous in situ stabilization. Why do not do the complete relocation? Because when you go for the complete relocation, there is actually needed, but it can cause avascular necrosis of the femur, which is the complication of the surgery. Okay, because when the femoral epiphysis will slip, okay, so it can cause the vessel will be affected, so it will result in the avascular necrosis of the femoral neck. Okay, and acute cartilage necrosis, that is called thrombolysis. Other thing is the deformity. Secondary osteoarthritis, 90%. When you need to apply the insufficiency one time, so the osteoarthritis in these patients can develop the osteoarthritis early in comparison to the other patients. The slip progression, 1 to 2% of single screw fixation. If you do the apply a single screw, so 1 to 2% chance that the slip will progress. And other thing is the hip stiffness. Okay. Now coming to the Perthes disease. The painful hip disorder of the childhood is characterized by necrosis of the femoral head. Okay, this is the femoral head. So there will be loss of the blood supply to the femoral head. The femoral head is supplied by metaphyseal vessels, lateral epiphyseal vessels, and scanty vessels. These are the vessels. Okay, so when the vascular supply is interrupted, so it results in the necrosis of the femoral head. When the femoral head becomes necrosed, it is called Perthes disease. Incidence in young and type 1 diabetes. Boys, and it's more common in boys in comparison to the girls. 4 times as often as in girls. Usually 4 to 8 years. The affected age is 4 to 8 years of age. When the patient comes with the pain around the hip at 4 to 8 years of age, so we should suspect for the Perthes and evaluate for the Perthes. Pathology. What is the pathology? There are 3 stages. In the stage 1, the brain will become dead. For example, the female head dies. When the blood supply will stops or with the interruption of the blood supply, so the female head will become die. So what? So every area will become die. There is a revascularization or repair stage. So new blood vessels enter the necrotic area and new body is laid down on the dead trabeculae. So either the patient go in the third stage or resolves. Then there is a mild form of the chronic femoral head occurs when the mild form of the left of the head dies. So sometimes the revascularization and repair process occur. So the third stage will becomes common. But third stage will occur when epiphysis is damaged and the growth and the head and neck will become distorted. It means the new vessels are formed in the necrotic area, but they're not enough to maintain the epiphysis. So epiphysis becomes damaged. The stage 2 will become stage 3. Epiphysis will become damaged and the growth of the head and neck will be distorted. Epiphysis ends up. So it will result in the flayed. The epiphysis will become flayed. This is called coxa plana and or enlarged. It's flayed but enlarged. So it's a coxa magna. Okay, and the head will become large but flayed. So there's the normal shape of the head. There is a normal shape, there's a round shape. The round will be the head will become flayed but enlarged. So again the femoral head will incompletely covered by the stapulum. What are the clinical features? Complain of the pain and start to limp. Okay, when the patient complain and start to limp at around 4 to 8 years of age, there is below 10 years of age, so we will suspect that. But if the patient comes after the 10 years of age with pain and limb, we will suspect the Sufi step develop. If the while in the Partis the patient is not obese, but in the Sufi the patients are obese, and the patient is obese and comes after 10 years. So think about the Sufi slip differently more hypothesis. But there will be no obesity and the patient comes below 10 years of age. It is around 5 to 6, it is between 4 and 8 years of age, or 4 below it is below 10 years of age to suspect for the Perthes disease. Okay, on examination, the joint is irritable. Okay, all the movements are diminished and extremely painful. The child is not seen till later. Okay, limited abduction and internutation. In this, in Sufi also the abduction and internutation are limited. While in clinical examination, there is also same clinical examination. X-rays. The X-ray will be different. What was there? We were drawing a line. We were drawing a line through the neck. Okay, and in the Sufi, but here we have to examine the epiphysis. Okay, this is the normal head. This is the normal contour of the head. But in this you can appreciate this. The head is not rounded, and it is filled with fragmentation, and this is the neck is also thickened. There is a contour neck. Okay, earliest changes increase density of the bony epiphysis and apparent widening of the joint space. Okay, this you can appreciate the joint space will widen because when the head will become flayed, so the joint space will become wider. Okay, and this is starting what you will see in the X-ray, increased density. There is a whitening of very white shape, whitening of the X-ray. White after date will be flaking, fragmentation, and lateral dispersion of the epiphysis. Okay, this is the when we draw a line over here, you can see this is the lid. The head is going to be displayed, so it is not fully covered by the acetabulum. Okay, with retraction and broadening of the metaphysis. Okay, this metaphysis is very broad in compared to the normal. What is the treatment? The treatments are non-surgical. That is what the most important thing is the head should be maintained in the acetabulum. That is the containment of the head. Okay, so if this is the patient comes in the earliest stage and the head is contained, but we see the changes. So what we will do, we will apply the skin friction for a few days, and we will get the bias bed rest and get access to painful things do nothing. Just avoid to do walk or avoid to walk and something. You will advise to bed rest, skin friction, and for pain control. That's enough if the head is contained. Abduction stretching, abduction splints, and no joint. Okay, this is the abduction. Okay, so important non-surgical treatment is very important. Okay, this is the skin friction. Just skin friction. The foot, the legs are abducted, and this is the foot friction. The flat patient is balanced. This is the abduction splint. Why the abduction splint? Because we appreciate in the X-ray the head was laterally placed. So when we do the abduction, the head comes in the acetabulum. So the head is contained. The important thing is containment of the head. Okay. Treatment. Treatment, if the head is not contained and still laterally displaced, so what we do? We do sometimes the panic osteotomy, we salter. Why we do the salter? Deepen the acetabulum. Or we do the female osteotomy, there is varus osteotomy. So they to maintain the head in the acetabulum. This is the varus osteotomy. Okay. And then when we do the varus osteotomy first, what we do, second time when we do a varus osteotomy, the head will become in contact with the femur. And very closely to measure, because these patients, most important thing that we have to follow, that is the head should be contained. When we find any sign that the head is going out of the acetabulum, so we will do surgeries. Otherwise, we will not do surgery. We will just go for observation, observe, and observe until the head is in the acetabulum. Okay, so what will you observe? The symptoms, definitely the healing process, in unilateral affection, we need to observe the other complication. The other complication is irritability. Irritable head. What is this? This is also called transient synovitis. It is the most common called acute head pain. Sometimes we do X-rays, we search for the pulse, so nothing is there, but the patient will feel pain. Why there is pain on the head? So this is the transient synovitis. So really it's a diagnosis of exclusion when trauma infection or when there is no trauma, when there is no infection, when there is no pulse and so forth, so and still the patient has pain. So we will label this with a pre-acute. And this is also the same age of the two members of age. It is more common in acquired endurance. This causes heart failure and arthritis, transit inflammation of the synovial of the transit synovitis, the synovitis, why this means inflammation. Okay, so it is the inflammation of the synovium. So the inflammation of the synovium could result in the artery. The artery is the pain in the joint, and arthritis inflammation of the joint. So there will be the inflammation of the joint, inflammation of the synovium, because of the inflammation of the joint. So the joint will be impacted. Okay, so remember what is the order of this? Remember what is the exclusion or what is the diagnosis of exclusion? Okay. What are the symptoms? Most commonly unilateral hip or groin pain. The patient comes with the limping. 50% of the patients have recent history of urinary tract infections, usually afebrile or have mildly elevated temperature. Very young children crying at night. What are the signs? Cold hip infection with slight temperature and external mutation. There will be no restriction of temperature and internal motion, but one-third demonstrate no limitation of motion. Which means in 70% of the patient there will be no restriction of the motion, it will be just pain. But in 30% you will find some restriction in the adduction and internal motion. Again, there is problem in the adduction and internal motion. In the Baptiste, same restriction, and Sufi, same restriction. And but in this thing, with a milder form, it means it has high restriction with the movements. The hip may be tender and painful when with the passive leg. The most sensitive case is the leg. The leg will not just hold the leg, when you hold the leg, it will be pain. What are investigation? Investigations to rule out diagnosis. There is we have to rule out the infection. Okay, so we will do the baseline. It's the WBC, PSI, CRP, C-reactive protein, and we will calibrate and receptive arthritis. So when we will do, there will be normal. X-ray scan exclude body regions, ultrasonic may show joint diffusion. What are the mannequins? The mannequins are apply heat and massage. Use dry anti-inflammatory drugs. Again, we advise the bed rest until the pain disappears and the effusion resolved. Okay. So this is the end of the lecture because I have covered the important topic. There are other topics in the pediatric orthopedics. The other topics out there, but the importance, these were the important and common topics that you may encounter